well-known professional in hematology world, and she's a pioneer in Baltic countries in the development of hematopoietic stem cell transplantation program, and the topic is Estonian experience in autologous hematopoietic stem cell transplantation.
Thank you so much. Ladies and gentlemen, dear colleagues, and especially dear inviters from the Kaunas colleagues part to attend the meeting and to maybe to share some thoughts. I'm not going to be too detailed, but maybe during the time we have had our experience, and not only, I have to correct the naming of the presentation, because we are having now 2 places in Estonia for transplantation, so that I'm going to present shortly experience in Tartu University Hospital, but autologous transplantation for multiple myeloma is done also in Tallinn Center in North Estonian Regional Hospital. And I'm going to target maybe the questions we have been getting during these times. We have been doing not only multiple myeloma transplantation in the cases of myeloma, but also connecting with others. The numbers are small, of course, if you compare with the centers who are doing more than 200, 700 transplants per year, but we have citizens in Estonia 1.3 million, so that I think by time we try to do our best to help our patients. So that you see the number is not big, it's only 57 patients in multiple myeloma, and honestly telling, only last more than 5 years I have been more thinking about multiple myeloma like a target for autologous transplantation. Of course, still I'm not happy, I must say, with this method of treatment for multiple myeloma. This is my personal opinion, not of my colleagues' own. Why I'm thinking that you will see further. You see, still there are lots of dead patients from that time. We have not been using as a standard tandem transplantation, but for some patients during the necessity, when the disease was coming back, and we again succeeded to have good results with the standard therapy, we have been using the second transplantation. And autologous plus allogeneic, this is a mistake. We have had 3 patients. 2 unfortunately died because of the transplant, infectious complications, but 1 is survived. And it's maybe, if I have time, I shortly tell about this patient, because it's demonstrating that as far as we are getting new opportunities in the treatment, we are making our patients giving more opportunities during the time to survive longer and longer. So induction regimens have been seen everywhere. Now, as we have also new components available, we can use new components. Mobilization has been all the time the same, and we have been happy. My colleagues are in the room. I have been discussing that also with them, but if something is working well, you don't need to change that. We have not been changing that. The mobilization results have been fine. And pre-transplant conditioning regimen, it's a lot of discussion in the literature whether it's too old, whether we need something else, and I know there are clinical trials going on to combine these old melphalan, but still working well. We will see what the future will take. Our patients have been, as usual, there have been also younger patients for the transplant, you see, and no really differences between the groups of still alive. The longest patient's survival not cure, but survival with different combinations of different treatments are more than 10 years. And I think this is not bad results, at least for some patients. And if you are looking, these are the data of our autologous stem cell transplantation. What is my question for you and high-level specialists who are going to give excellent speeches today, that if you see here lymphomas, this is almost we never expected more than 20 years ago. But here we see what is in myeloma. So that what I would like to have myeloma patients on the same level as lymphomas. And I have much more clever specialists here to tell it how to do it. And from survival, I'm not going also in details, but death has been, of course, unfortunately, accompanying the patient's fate. And reasons have been different, but mostly disease progression. And it's well known that all the diseases are having the face of patient, but especially myeloma, because every patient really has his own multiple myeloma, and you never know how we have perfect genetical markers now, but we still don't know what to choose for individual patient. So that the questions for the future are the same as they have been several years ago. We really want to reduce the risk of relapse and extend the progression-free survival and overall survival. These are the important aspects. And what can help there? What future can present us? What opportunities we are? We still have to think what is the best induction treatment prior to autologous stem cell transplant. What are the best mobilization procedures? And also the optimal conditioning regimen. Is still a melphalan or something else in addition. Also, last year's very important question about consolidation and maintenance. In US, maintenance is already the standard after autologous transplantation. How long? In which way? And just last year, discussing these aspects in Dana-Farber Institute with Professor Kenneth Anderson and Nick Hilmunchi, they have been very sure that, at least in our days, we can't go without maintenance even after autologous transplantation. And they have very good results on that. So we have to think about that. And we have several new drugs which can really improve the fate of our multiple myeloma patients. Still, we have clinical trials, but we don't have much population-based studies. You know, in clinical trials, the results always are better than in real life, because excluding criteria are to take away patients with comorbidities, what we are having in multiple myeloma very often. So that what is the place and in which patients we need to do as a first line, whether we need to do that up front, as is all patients as we are doing now, or no, or only for those we have suboptimal response. I think it's very important questions, and it's very much in the paradigm of individualized approach in not only in multiple myeloma, but in all diseases we are having on the table today. So I think we still have much to be learned. Still, actually, autologous stem cell transplantation is likely to remain an important option. But in the all complex of treatment, so that it's not submitted by himself or herself. I don't know what sex is transplantation, but I think we have to take into account all the complex, from the very diagnosis or the progression or progression-free survival, and how this concrete patient is doing with that. And this is a tricky thing. It's a matter of art of really treating the patients. And just to show also how our autologous transplant curves in Tartu University Hospital, you see, first has been done in 1993. Most of the patients have been lymphoma and myeloma patients, some very rare patients with solitary tumors, and some other malignancies. And allogenic stem cell transplantation is, in numbers, has been increasing significantly thanks to having an opportunity to have unrelated donors through the Finnish Red Cross stem cell registry. That has been a great help from Professor Tabani Ruutu, who really helped us to become the partner of Finnish Red Cross stem cell registry. And now we have also like the part of the registry in Estonia, now with more than 300 Estonian people really agreeing to give their own stem cells for other patients, not only in Estonia. And we have been starting in 1991 to organize and establish these activities. We have been entering with head nurse, two of us in the empty corridor and empty rooms. So we, step by step, lots of colleagues have been joining us. In my age, we are looking, showing the pictures from earlier ages. My colleagues, of course, can show other pictures. Actually, the matter is I had this available, this picture. But in our days, we can show ourselves, and I know our colleagues. Dr. Ainkaare, please show up. He's the head of hematology and transplantation department now. And Dr. Jane Lehtmaa. And Dr. Mari Punav. So, you see, they are just have not been changed. So the work has been very encouraging, and they are very enthusiastic. And I have colleagues from Tallinn, North Estonian Center. So please, yeah. So I think it has been told already in the beginning that we can do all only together, and when starting in very, very scarce facilities in Children's Hospital, in rooms where we really try to renovate each room. So we are happy to have now more than 4 years new facilities in Tartu University Hospital for hematology and bone marrow transplantation. I think it's really excellent for our patients, for our colleagues who can do whatever they want, because you don't need to go around business people to find some money, but you just need to think what equipment you need to have, so that I'm happy about my colleagues who can work as enthusiastically as they want. And I think with aim, we every time have to think about what we really want to obtain with this and that method of treatment. It's not by himself, it's a matter of results. And I so much like colleagues in America having a very targeted attitude to do the things which are really giving the best results. I think we are capable of doing the same for our patients, as ultimate aim is cure, and for multiple myeloma, we still have lots of work to do for that, and maybe we need some new paradigms, understanding for this disease, and if we understand the disease better, we can propose the best treatment. But we need to have all options, and I am so happy that colleagues in Kaunas can provide to their patients all options for multiple myeloma treatment, and bon courage, happy way. But you can't turn back anymore. Thank you.
Thank you, Professor Everaus, for your experience. I suppose you are EBMT member, of course?
Yes, from the very beginning.
Very good.
I got to be, for my surprise, even in 2014, to be an honorary member. I don't know why.
Very good.
The last year you made 20 allogeneic transplants. For what diagnosis? Did you have any myeloma included in that?
Not myeloma. When was the last myeloma in? I think 3 years ago. 3 or 4 years ago. Yeah. And this is a unique patient. He has been treated first in Tallinn Center, having an autologous transplant very well, with good results, and then relapsed, then had the second autologous, and straight after that had allogeneic. It was not very easy for him, but he passed well, and everything was okay. But then he got relapse quite soon. Then it was a donor leukocyte infusion given, again with quite good results, but then he appeared to have a plasmacytoma outside the bone marrow. Then it was irradiation and systemic treatment, and then after a short period he got in brain small plasmacytoma. Then he has been irradiated. And what to do first? And then he has been getting a systemic therapy, and we have had an opportunity, as Professor Munshi has been visiting for lectures at Estonia, and we put together our opinions in our department and discussed, and what he suggested really maintenance therapy, and now it will be almost 2 years maintenance therapy, or bortezomib and lenalidomide, doing well. He's a journalist making his professional work. So that, it's so unique. And most important is not to give up. Not to give up first for doctor, and not to give up patient.
Okay. So you asked some questions in your presentation.
Yeah.
So
I think
just a second, we will do that.
Okay.
So the first question is maintenance. Now we will see some answer from our experts here, and perhaps Gösta and Laurent and Professor Holowiecki and Norbert, if he wants, could tell you what to do or what they are doing.
Very good.
Well, it's really a difficult question. I mean, there is a pressure for doing maintenance now, and it should be lenalidomide if you believe what people are saying.
You have lenalidomide?
Yeah.
And
Okay.
you can use it as maintenance?
Not yet.
Aha. Okay.
The last information I had from Dr. Attal, but you might have other, that is now overall survival is better with maintenance. Is that right?
So it is very controversial, as you mentioned, and actually the last time I heard Michel Attal a week ago, he mentioned that they did meta-analysis, the American study, the French one, the Italians, and apparently, and this will be presented in ASCO, which is 2 weeks ago, And apparently, yes, there is an overall survival advantage in this meta-analysis. So therefore...
With what? With Revlimid?
With Revlimid, yes, sorry. Revlimid maintenance post-autologous stem cell transplantation as maintenance. So is it going to be a new standard? I don't know. In France, currently, we do consolidation, but we do not do any kinds of maintenance, but it may change.
And it's very much depending on financial issues also, so it's not really very cheap.
That's a very important question. We're talking about autologous stem cell transplantation and new drugs. I mean, we will address that. But currently, if you combine the new drugs, we are talking about 10,000 euros per month per patient. So that also should be taken into account.
So they don't have Revlimid, and not even in Lithuania they have Revlimid now for maintenance. They have it for, I think, for relapsed patients. And I don't know what is in the other country. Dr. Trakchugas, could you tell us if you don't have Revlimid? So the question doesn't actually work. So what's about thalidomide? You have thalidomide?
Yeah.
For maintenance?
Not for maintenance.
Not for maintenance. So we cannot answer actually the question. Okay.
So I'm strongly for doing maintenance based on Ludwig's meta-analysis that shows advantage both in terms of progression-free survival and overall survival. We do it in personalized basis, so in patients who tolerate fine thalidomide, we continue then after transplantation, and also in patients who need it. It means if you look at clonal protein, there are convincing data with lenalidomide and all other drugs, but the price is of course an issue. But I would come back to your very important questions when you did show these curves showing inferiority of the results in plasmacytoma. So if you ask my personal point of view, so I think we are guilty because we have broken all definitions of classical autologous transplantation, which should be started in patients with complete remission, to put down by 2 logarithms the probability of progression. And practically now, both for harvesting, patients are sent in partial remission, and then we are satisfied with so-called very good partial remission, which is, well, sorry for... it's stupid.
It's a very important...
This was found by chance in one study. It was false from the statistical point of view because it was not the goal of the study. And according to present rules in statistics, it was not correct to put it to conclusions.
I agree completely. Yeah.
I just can mention that we tend to use maintenance therapy in Germany, I guess. And just one anecdote, I have one patient who is for 17 years on interferon, and he still has myeloma. It's sure, because the IgG never was normal, and he is responding. Very low doses of interferon. This is, of course, an anecdote, but it tells you that it's sometimes it's just the individual experience and response of patients. So he's still quite happy with it, and he's very much hesitant. I discussed it many times with him to switch to another drug or try, to stop it. No, I want to go with it.
Maybe maintenance can be really. I don't mean it can be years and years and years. Maybe some period after transplant. Maybe, I don't know. Nobody knows. So, but the issue to think, because still we know that the other our enemies. I mean the myeloma cells, and especially if we are keeping in mind the opportunity that they have their own stem cells, myeloma stem cells. waiting for the opportunity to come back again.
So I would be very interested to see the ATAL data dash. You know, we have also problems to administrate enough Revlimid after transplant because we have a lot of toxicity, hematological toxicity, but also neuropathy. And I'm not convinced if really we should use this, especially if it's so expensive and the budget is limited. I don't know, but I think it's not wrong to do it this way or the other way. So we didn't give you an answer.
Yeah, it's usually in medicine. Okay. We never have full answers, never. Okay, thank you for attention and excellent discussion. Thank you.
Thank you.